And this is controlled by 4 or 5 muscles. Your 2 main muscles are your temporalis muscle and your masseter. And then you have some supporting musculature. You have your medial pterygoid and your lateral pterygoid. Most of the images that show the pterygoids have the buccinator muscle there. This is a cheek muscle. It's not involved in mastication, so it helps puff out the cheek, but it's there. Your textbook has this image here with the temporalis masseter. Also shows this muscle here that again is not part of mastication. So you're really looking at these 4, temporalis, masseter, and the medial and lateral pterygoids. And you have a couple heads here and a couple heads there, but you have 4 main muscles. You have a whole set of muscles that are outside of the jaw, below the jaw. You have the suprahyoid muscles. You have 4 or 5 of them there, and you have the infrahyoid muscles, and you have 4 or 5 of them there as well. And depicted here are some of the cervical muscles that we will get to in our next chapter. But for now, let's look at the suprahyoid muscles. So these are the muscles that are above the jaw, or above the hyoid bone, below the jaw. You have the mylohyoid, genohyoid, and then not depicted here, you have digastric muscle, and I think that's in the next slide here. You can see the anterior and posterior digastric. And these muscles, basically, you can see the line of pull. When they contract, they're going to help in opening the mouth, so more in fine motor control. The hyoid bone is floating there. It's not connected, so it needs to be supported somehow as well, and that's where the infrahyoid muscles come in. So the suprahyoid muscles that are below the jaw, that are above the hyoid bone, they directly open up the mouth. Mandibular depression, they're going to pull it down. And then in order to keep the hyoid bone from actually moving towards the jaw, because it's actually lighter and smaller than the jaw itself, these muscles that are connecting to the torso, which is bigger and heavier than the head, they're going to anchor that hyoid bone down. So that's what the infrahyoids are doing. They are stabilizing the hyoid bone so the suprahyoid muscles can do their work. And you can see here there's quite a bit of anterior neck musculature, like the SCM and the traps, and there's some deeper muscles here. We'll get much into this when we look at the cervical spine, but you kind of appreciate this, the suprahyoid muscles having this anterior connection. They have a pretty good moment arm for controlling head, and so as long as the jaw is fixed, if you have the masseter and the temporalis keeping the teeth clenched together, these anterior neck muscles that are really supposed to be just depressors of the mandible, they are involved in anterior neck stability. And there's a reciprocal relationship that exists, as we'll discuss in the posture aspect, that dysfunction of the jaw can lead to dysfunction of the anterior cervical muscles and put more strain on the muscles here. So some neck pain can cause jaw issues, and jaw issues can cause neck issues. So when we look at these muscles individually, we'll start with the temporalis. We'll look at the most superior, and as we said, it kind of tucks behind the zygomatic arch here. And you have the masseter, which is on the outside. These are your 2 strongest muscles for chomping force, for bite force. The temporalis, you can see the lines of pull through the arrow, and it's going to pull up, and you see it tucks behind the zygomatic arch, and it attaches to that coronoid process right here. So you have 2 of these processes that go tuck back behind the zygomatic arch. Yeah, the next muscle is the masseter, and it has 2 heads. It has a deep head and a superficial layer, if you will, but heads. And you can kind of see it attaches all along the zygomatic arch and tucks down behind the angle of the jaw. So it's very superficial, and you can see the deep layer there that it doesn't quite make it to the angle, but at least still near that coronoid process. And when you see a cross section of this, you can appreciate how thick it is. It really is a thick muscle. It's not nearly as thick as the glute, but I always think of it as like the glute of the mouth. I mean, it's a powerful muscle, and most of your biting force is coming down from that muscle itself. Then we move to the inside muscles. So those are the superficial. We're going deep. We're looking at the lateral pterygoid and the medial pterygoid muscles. And you can see that they have a more horizontal type orientation, almost oblique. And we'll look at the lateral pterygoids first, and we talked about them a little bit in terms of their involvement in opening up the mouth. And you can see that the inferior head here attaches to the condyle, and then you can see that the superior head here is attaching to the articular disc. And they get the same signal. They both go, and it's supposed to be coordinated appropriately. And as this is pulling on the disc, this is pulling on the jaw, and then hopefully the gravity's taking over, aka the masseter and temporalis are getting out of the way, or those hyoids are coming in and helping with that mandibular depression. And you can kind of see the angle of pull here, and this will be appreciative when we look at like lateral deviation. And you can see that trying to pull the jaw to the left, that's going to be lateral pterygoid. And same thing with the medial pterygoid, because they're on the inside of the jaw versus outside, they're going to have more of a medial deviation, where the outside muscles are going to have more of a lateral pull. So then here's your medial pterygoid, and it shares in name only with the lateral pterygoid, because it has more of a vertical pull versus the horizontal pull, and it basically does what the masseter does on an inside aspect. So if you look here on the right side of the jaw, you can see the masseter on the outside, you can see the temporalis, and you can see the medial pterygoid has a very similar line of pull with the masseter. So between these two muscles, all three of these muscles, they have a big resultant force in mandibular depression, or I'm sorry, elevation in terms of closing the mouth, so your bite force. You can see the lateral pterygoids are cut, but these would be running across this way to help pull on that disc as the mouth is closing. So here you can see all of them together with the muscles cut. You can see the deep layers here of the pterygoid, some of the muscles of the cheek and palate, and then you can see appreciate some of the hyoid muscles that are there. So it's a big sheet of musculature that's involved in supporting this opening and closing. So when we look at elevation, so closing of the mouth, you can see the temporalis has a decent line of pull, but the masseter and the pterygoid, medial pterygoid, have the direct line of pull. And you can appreciate a little bit that there's a really big vertical component here, but you can see that there is a little bit of a horizontal. So when the masseter and the medial pterygoid are closing, they do have a tendency to pull the jaw forward, but that's counteracted by the horizontal component in the opposite direction of the temporalis. When we look at depression coming down, there's not a lot of muscles that are here to do that. You have the lateral pterygoid, and it's just assisting in that anterior translation, the inferior fibers. The superior fibers are pulling on the disc, and then you have your whole suprahyoid muscle group supported by the infrahyoid pulling that jaw down. And here again with the depression, you can see that with the protrusion, that superior fibers there attaching to the articular capsule, pulling on the disc, and then you can see the inferior doing that protrusion to help with that depression. When we look at protrusion, then we see that the lateral pterygoid has the best line of pull for that. And as I talked about earlier, you have those horizontal components in the masseter and the medial pterygoid. They're also involved in that anterior translation. And then for retrusion, it's going to be the suprahyoid muscles. You can see that they have that pull. And it's temporalis now that's coming in that is involved in pulling that jaw back. So you look at this and you got to go through the chart and look at who's agonist, antagonist for each of the movements. And when you look at, let's say, elevation, you'll see temporalis and masseter are agonists, but in aspects like protrusion and retrusion, they become antagonists. So just make sure you're going through and looking at the muscle responsibility. When we look at lateral deviation now, muscles that are going to be external, lateral, are going to pull the jaw into that direction. And on the ipsilateral side and on the contralateral side, you have muscles that are medial. So you can see that the lateral and medial pterygoid, they're on the inside of the mouth, so they're deep, more medial, and they're going to pull to the contralateral side. And the temporalis and masseter, they're superficial on the outside of the jaw. They're going to pull to the ipsilateral side. And you can kind of see that here with the medial and lateral pterygoid. Again, you can see the direction of pull, and so looking at what joint action you are doing. And again, you can appreciate the temporalis and the masseter on the outside pulling the jaw in this direction, because you can see their vertical components are opposite of the medial pterygoid. It has more of a medial vertical component, horizontal component, and the temporalis and the masseter have a lateral horizontal component. And this is just a recap of looking at the muscle function. You can see that you have just a few little tiny muscles that are involved in opening in the mouth, so depression. You have the infrahyoids supporting the hyoid, the suprahyoids pulling the jaw back, and you have the little lateral pterygoid pulling forward, and the even part of the pterygoid just directed at moving the disc. And you have these massive muscles that are involved in closing, elevation, and closing the mouth. And this is because gravity is down, and you don't need a lot of muscle force to open up. If anything, opening the mouth is going to be a gravity situation. You're going to have an eccentric control of these muscles. And when you look at the amount of bite force, we're more interested in having a strong elevation and not so much a strong depression. The forces that are being generated here, significantly much more muscle mass and forces in closing, and just a little bit just for fine motor control for opening. The disc, this is where we had said there can be some dysfunction, and you have to have this coordinated timing where this is opening up. You can see the condyle here. As it comes forward, it's going to protrude forward, and that disc needs to come along with it. And that's done by the lateral head of the pterygoid, the lateral pterygoid, the superior head, and the inferior head is timed appropriately for this to occur. Now, if this doesn't occur in this nice sequence, like it's supposed to be doing here, right? You can see in this phase of opening with full opening here, maximal depression, and then maximal elevation, you can see that the timing as the jaw is opening, as the mandible is dropping down, you can see that the disc is coming forward, and then it's being pulled back in those movements, right? So that's the sequence that's supposed to be happening. When you have the jaw closed, you're going to have good congruency, articulation between the contacting surfaces, and when the jaw is open in that bottom position, you're going to have good congruency. Now, one of two things can happen. You can get what's called clicking, and a majority of the population has this, where you open your mouth too much, not even too much, but there's a little pop or click, and what's happening is that the timing, the disc is free to move, but the timing is off. So it's almost like the jaw's opening up and then this is getting popped through either on the opening aspect or on the closing aspect. What can happen in locking is that you have a mistiming now of where the joints are. So it might be timed off so much that the disc is never fully getting back or getting out of the way, and so you get the stuck aspect. And it doesn't always happen on both sides. It can happen on one side, not the other, and that's where this is where you look at the dysfunction. You can have pain, and that's usually tied to a timing aspect because you have a bone-on-bone type aspect, and you don't have that nice cushion between those two surfaces. So this would be the clicking aspect, where the jaw's opening up and it did not time appropriately and has to be popped out or pulled out in order for it to move through. You can get clicking on the opening here. You can see that better here where this disc should be back here, but it was pulled too soon, and then getting locked and stuck and not coming back as it's coming forward. So there's either a tear or stretching here or some muscle weakness or incoordination with these fibers there. This is your normal sequence. That's the same sequence we looked at again. We could look at the opening and closing, and then you can see here also the locking, where the disc is actually way back behind, the condyle moves forward, and you're locked in position. So again, when we look at these aspects, this all has to do with the neuromuscular control of looking at how the hyoids are working in conjunction with the pterygoids and making sure that everything is moving accordingly. Now, why this gets out of sync is typically because of postural distortions. And what came first, the chicken or the egg? Was it the actual posture distortion, or was it the dysfunction that led to it? But when you have when you can look here, when you have this forward head posture, which is extremely common in a tucked under tail position, when you look at a posterior pelvic tilt, or from on your device or computer, you can start to get misalignments or muscle imbalances between these two, and you start getting timing issues with the components. What can happen too sometimes is you can have some instability in the cervical spine, and the deep muscles here that are supposed to be providing anterior stability, these are doing the work and compensating for those. And so you can kind of see here the SCM and maybe the longus colli and some of the cervical muscles we'll talk about. There's a whole bunch of things that are related to this in terms of open mouth breathing, tongue position is a big thing in terms of this. When you're lifting or doing any kind of extraneous activity, just normal resting position, the tongue should be at the roof of the mouth, tucked behind the teeth. And so this is a posturally correct jaw. This is a posturally incorrect jaw, so unstable versus stable. And this is what it's supposed to look like. The bottom teeth are removed, so you can see the tongue's up against the roof of the mouth, tucked right behind the top of the teeth, and that's what this looks like here. As opposed to this here, like the open mouth, forward head posture, weak aspect here, inappropriate tongue position, and this can be related to dental aspect, bite alignment, dental crowding, or just habitual stuff over time from positioning. And so we look at this tongue, again, the tip of the tongue behind the teeth, and you should have somewhat of a contact between 2 and 3, and then 4 starting to come out. So you don't need to have your tongue way up against the back of your palate, but it should definitely sit comfortably behind at the top of the mouth behind the teeth. If it doesn't, like when you look at the resting position of the mouth, your teeth are closed. There shouldn't be any open space. There's actually quite a bit of overlap between the top and bottom teeth. And so you can look here at this ideal position where you have perfect alignment, so you're orthodontally correct, right, at 90-degree angle, versus having a tendency to have a passive retrusion aspect where the jaw is pulled back, or a passive protrusion aspect where the jaw is too forward. And that could be related to structural component or functional component or both. So is it the hardware or software looking at that? But your teeth should overlap a little bit. About 50% of the top teeth overlap with the bottom teeth, and that is designed that way. And you can have some underbites and overbites. And again, this sounds like dental aspect, and it could be a structural component. But a lot of times this is related to functional, and we have that. I shared in that lecture a long time ago that structure dictates function and function dictates structure. And we look at that the positions that you put your tissues in, your hardware, can adjust software and the muscle length change from that. So although this is meant to be a TMJ and looking at jaw, this is our first conversation. We start looking at posture, postural distortions, and dysfunctions that are related to that.